Ladies and gentlemen, please welcome System Medical Director, Behavioral Health, Swedish Health System, and System Medical Director, Telepsychiatry, Providence Health and Services, Arpan Waghray, MD.
Hi, I'm a psychiatrist and I work on the acute care side. So I spend a lot of time with patients during some of the most difficult times in their lives, some of the darkest hours. And this truly is a privilege. This is a privilege that I definitely can never take for granted. And we want to be able to serve more patients. We are in healthcare because we want to be able to serve our poor, our vulnerable, provide access to care to those who are in underserved areas. Yet, this is difficult to do, and telehealth provides us an opportunity to deliver care and reach patients in need. It also gives us a platform to deliver newer, more effective models of care. And today's behavioral health system, nationally, continues to fail our patients on a regular basis. But it doesn't have to be that way. It doesn't have to be that way if we have the service user at the heart of everything we're doing and we design our care around them. And that's what I'm going to talk about today. I'm going to talk about 5 real people across the continuum of care, their stories with the behavioral health system as it is today. What is today, but then what can be with the integration of telebehavioral health in a patient-centric approach. Mr. Jones is a 56-year-old gentleman, works in construction, and lives in a very small rural town of about 2,500 people. Now, he hurts his back at work and is in excruciating pain, so he started on opioid medications by his primary care physician. Unfortunately, other life events occur as well. He has a lot of financial stress, difficulty with relationships, and he starts becoming more depressed. His doc wants him to see a psychiatrist, but the closest psychiatrist is about a 2-hour one-way drive. He does have a social worker in his community who could help him, but she's also involved in his child's school as well as his church, and he's ashamed to reach out to her for help. The stigma prevents him from getting any help. So he starts self-medicating on opioids, becomes more withdrawn, till one day, his brother, who becomes concerned about him, goes to his house to find him passed out, unconscious, overdosed on opiates. Mr. Healy is a 35-year-old gentleman with a schizophrenic history and stops taking his medications at some point when he starts feeling a little bit better. But then he gradually starts decompensating. He's pacing around, becoming more paranoid. His mother knows that something's not right, something is not working, but she doesn't completely understand how serious this is, till one day he disappears. She then contacts law enforcement, who find him in the nearby woods, crawled up in a fetal position, extremely terrified, seemed very dehydrated and hadn't slept for a while. They bring him into the closest critical access hospital to the emergency department. Now he's medically evaluated and cleared, and the path that they're going to take is to admit him to inpatient psychiatry. But as it happens very commonly, there are no psychiatric beds available. He's in this emergency room, extremely paranoid. He's convinced that people are coming after him, they're going to torture him, and they're going to hurt him. So he tries to run away. He tries to run away a couple of times, and the staff prevent him from going. Security, nursing staff now feel threatened. He becomes physically aggressive towards them, and they don't know how to deal with this. They have to keep him safe, so he ends up in behavioral restraints. Not for 2 hours or 4 hours, but for 72 hours to his entire stay during that emergency department visit, till a bed becomes available. No psychiatric consultation, no psychiatric treatment plan, no medications. His mother is sitting at the bed by his side, extremely distraught, profoundly helpless, probably in more pain than him. Emily is only 15 years old. She has a history of trauma. She has severe PTSD, but never really got any help. She starts drinking alcohol to help her sleep better at night and to deal with the PTSD symptoms. Like a 15-year-old, she's involved in a relationship. This is a very volatile relationship, and has a breakup. At that point in time, she thinks that her world is over. She thinks nothing's ever going to get better, and thinks that she's better off dead. In a very impulsive act, she overdoses on a full bottle of Tylenol. Doesn't tell anyone. Till the next day, her family find her very physically ill, throwing up, and then she tells them what happened. They take her to the hospital. She's admitted to a medical floor, where now she's found to have significant liver damage. She's actually put on the list for liver transplant surgery. But for her to participate in that program and to be successful, she needs to get counseling for her alcohol dependence. She needs to have her untreated psychiatric symptoms addressed. But we have a siloed behavioral health and medical health system that was not designed with Emily in mind. She ends up on the medical floor for 2.5 months, considered too fragile to be admitted to the addiction recovery program or for counseling services. No counseling for her alcohol dependence, no therapy for her PTSD, no real psychopharmacological help, and continues to suffer physically and psychologically. Ms. McKenzie has severe postpartum depression. She has a 6-month-old and is so depressed that she's unable to care for herself or for the baby. Now, to complicate things further, she feels extremely guilty for being depressed. She feels like she's a really bad person because she has this beautiful blessing, and she should be enjoying this blessing, but feels depressed. She doesn't understand what's going on, but luckily has a good relationship with her primary care physician. She talks to her primary care doctor about this, who explains what postpartum depression is and starts her on some treatment. She doesn't respond. She doesn't get better. He wants her to get more help. She needs a psychiatric consultant. She needs some cognitive behavioral therapy. But the stigma prevents her from getting any help. Now, she continues to suffer, but so does her primary care doctor, who feels helpless, doesn't have the tools to assist her. Mr. Wilkie is a 72-year-old retired pilot who's gained a few pounds. He smokes a pack of cigarettes a day. He has poorly controlled diabetes and hypertension. And every time he goes to his primary care physician's office, he gets a lecture. He gets a scolding that he has to lose that weight and he has to stop smoking. He wants to do it, but he just doesn't know how to. Now, this continues. He feels like a failure, and he's so embarrassed that he stops going to his primary care physician altogether. Now, I'm not suggesting that telepsychiatry is the solution for all these problems, but I think this is something we have to think about. We have the patient at the heart of everything we do and design care models around them. There are effective models of care that we could use. There are, in addition to just providing access and reaching people in rural, remote parts of the country, we have other things that this technology can allow us to do. There are psychiatric care teams where a psychiatrist, along with the social worker and primary care physician, can coordinate and deliver care to their patients. There are asynchronous telepsychiatry visits that can happen that can help delivering better care. There's a model called Project Echo, which is absolutely spectacular. It's a multidisciplinary care team that uses best evidence-based practices to disseminate knowledge in rural parts and in other places, so breaking the walls between specialty and primary care. There are opportunities to have joint visits with your primary care physician. Think about how powerful this can be, especially for the stigma and better coordinated care. Now again, our system was not designed with the patient at the heart of everything. But if it were, and we were integrating telebehavioral health, Mr. Jones could have received a psychiatric consultation in his primary care physician's office. He could have been started on an antidepressant regimen. We're well aware that pain and depression do more than mutually coexist. They cause each other. He could have received cognitive behavioral therapy from the comfort of his home, avoiding the stigma. Now, the shortage of psychiatric beds is still a problem, and telehealth is not going to help with that. But there's no reason why Mr. Healy could not have received compassionate, good care in the emergency department, could have received a comprehensive psychiatric assessment, could have been started on a treatment plan. His mother who was sitting there and completely distraught, could have been included in this discussion so that she would understand that her son is now getting the care that he needs and is on a path to recovery. The staff feel terrible for leaving a paranoid person in behavioral restraints, but that was the only tool that was available to them. Like I said before, the siloed behavioral health and medical health system was not designed with Emily's best interest in mind. It might be more convenient for us, it might be more convenient for the payment systems that we have today, but it was definitely not with Emily in mind. There is absolutely no reason why she could not have received the care she needed. She was on a medical floor for 2.5 months. She should have received counseling for her alcohol dependence. She should have received cognitive behavioral therapy. She should have got on the path to get the liver transplant surgery and the recovery that she needed. Perinatal mood and anxiety disorders are way more common than people think. They're 15 to 20% patients suffer with these conditions. And this is where there's a lot of stigma. The stigma prevents most people from getting help. But it doesn't have to be that way. Now, think about this time in one's life. This is probably the busiest time a person can have. And we expect that somebody who's severely depressed, has this infant, has to arrange for childcare, figure out something, drive half an hour or an hour to have a cognitive behavioral therapy session on a weekly basis, when what we should be doing is taking the care to them in her convenience of her home at the time that works for her. If people could stop smoking and lose the extra pounds they wanted to very easily, they would have. People want to live healthy lives. It's hard. But there are tools that we can use to assist them. Decisional balance, motivational interviewing, problem solving. There's no reason why these tools could not have been used to help Mr. Wilkie from his iPhone, from his iPad, and the convenience of his home. Now, this is not a dream. This is happening today in different parts of the world, different parts of our country. In our own system, we've been using telepsychiatry in the Spokane region, Oregon region. It's Swedish for 5 years now. But now we're getting together to do this in a much more organized, deliberate fashion. It's also very important that when we leverage the technology, we don't compromise on some very critical aspects of the patient-physician relationship, the relationships with the teams. And we're putting a lot of effort in making sure that we're able to pay attention to these details while we launch and develop these programs in various emergency departments. We then will go to primary care next and other ambulatory care settings and provide in-home care as well. Now, this takes a village, and here's ours. Thank you.